My name's Sandra Dyer. I'm the clinical lead for the Community of Practice, which is now hosted by Central London Community Health Trust. So welcome to colleagues across London and nationally. I'm just going to take you through housekeeping, tell a little bit about the Community of Practice, and then hand over to our speaker. So just a little bit about our Community of Practice. It's been running since February 2023. We're London-based, but for our webinars, we always invite people from around the country and beyond. So probably the majority of people on the call today are London, but welcome to national colleagues. And quite nice if you pop in the chat where you're from and what your role is. So just get a sense of who's on the call today. And essentially, our Community of Practice brings people together around the topic of cancer, working in various settings. So from community, primary care, and our specialist colleagues working in secondary care. And I'm going to tell you a little bit about what we've been doing so far and what we've got planned for 2023. So 2025 even. So these are the topics that we've covered so far. So we've had something on frailty and cancer, lots of work around integrated working across boundaries. We've covered health inequalities, cancer risk assessments, cancer rehab, cancer old people and frailty. And we're making plans at the moment for 2025. So we're thinking around opportunities to discuss AI and digital technology around early diagnosis and supporting people living with after cancer. Thinking about needs of Asian communities in relation to cancer care, and also looking at London Care Plan and integrated personalised care into that, and much more. So if you want to hear about our forthcoming events, you can join our mailing list and pop the QR code on the slide here, and there's also links on the slides here to take you straight through to our website and where you can see previous events that have been recorded. Okay, I'm now going to hand over to our speaker today, Irene Dodson, who is a diabetes specialist nurse in Cheshire. So over to you, Irene.
Okay, so when I was first asked to do this session, it was how on earth can I fit it all into an hour? Bit of a challenge because it's a huge topic. So I've been through what I think are the objectives from a specialist nurse point of view. However, before we go on to the objectives, I'd like you just, if you can, to pop in the chat or put your hand up and what is it that you want to get out of the session. Hopefully we've got the same ideas. If not, we're going to have a little bit of a challenge. So yeah, I have got a little bit in there on steroids and people going through cancer treatments, and also, oh gosh, they're coming through really quick now. Yeah, blood glucose while on chemotherapy is definitely one I'm going to cover, and how it's going to affect the diabetes. So it looks like we've got pretty similar ideas, so that's a bit of a relief. Okay, so if we start to look at the objectives, is to recognise the importance of good control during cancer treatment. So we know that if people's glycemic control is good, then the cancer treatment is going to be more effective. So it's really, really important that we don't ignore the fact that people have got diabetes, and we don't ignore the fact that potentially cancer treatments are going to cause diabetes as well. So the next one, I sort of want you to be aware of the challenges of diagnosing diabetes during cancer treatment. So quite often when we're looking at diagnosing diabetes, the first thought we have is type 2 diabetes. But I've just got one slide I wanted to put in about immunotherapy and the risks of type 1 diabetes. And then we want to make sure that we're picking the most appropriate diabetes treatments to use during cancer therapy. I want to get over, if I can, how important it is to monitor glucose levels. The number of patients that I've had that have been that have come to me, they've had to stop cancer treatment because they've been so symptomatic, and actually they've developed diabetes, and it's the osmotic symptoms from diabetes that has caused the issue, not the cancer treatment. So obviously we want all our patients who start cancer treatment to finish if they can. So, and then I want to sort of go through how to safety net and prepare patients to come through to the diabetes specialist nurse team. And we want to also make sure that they're swiftly referred, so we identify them really quickly and get them through to the diabetes team. So we're going to start to look at the priorities of diabetes treatment when we've got somebody going through cancer. So we've got one answer on there already. So what would be your priorities if you were thinking about diabetes treatment in cancer patients? What are our priorities with cancer patients? We've already got nutrition on there. Anything else that you'd think of as a priority? So yeah, absolutely, symptom management, side effects of treatment and side effects of the diabetes and the cancer treatment. Good fluid intake, yeah, regular monitoring. Fabulous. So we're thinking along the same lines, so this is good. So people with diabetes treatment in cancer patients, we want to make sure that we've got that good nutrition, and nutrition becomes the most important thing rather than the glucose levels. We can change treatment to keep on top of glucose levels, but we don't want to stop them eating. They're not going to necessarily feel like eating what they should eat, so we just want them to be eating. We want them to be able to maintain the weight, and preferably a lot of them we want them to be able to start putting on weight. We certainly don't want them to be losing weight. And symptom control, which has already been said already. So we want that symptom control to be minimal from any diabetes side of things. So it's very, very difficult when they're going through cancer treatment to determine whether some of the symptoms are from diabetes or whether some of the symptoms are from the therapy that they're on. So if we can get the diabetes as under control as possible, so we can rule out symptoms from the diabetes, then it means that you can concentrate on the cancer symptoms, so that we can hopefully get our patients through that full journey. Quality of life obviously is one of our main things. We want to make sure that the time our patients have got is quality time. So relating back to the symptoms, we don't want them to have symptoms throughout their treatment, and we want to optimize the efficacy of any cancer treatment that they're going through. So we know if people have got hyperglycemia and the glucose levels aren't controlled, then cancer treatment isn't going to be as effective. Okay, so if we were looking, we've already said that monitoring is really, really important, and there's two types, general ways of us testing glucose levels in diabetes, which I'm sure you're all aware of. So we can do our glucose monitoring, so our day-to-day glucose monitoring that the patient will need to do themselves, or we can do an HbA1c. So what's the difference between the two? Do we know what the HbA1c shows? Yeah, so our HbA1c is a 3-month average. So when we've got patients going through cancer treatment, we need to consider their cycles of treatment, and quite often it's going to be every couple of weeks, every 3 weeks. And if we wait 3 months to see whether the glucose levels have changed by waiting for an HbA1c, then we're going to have missed the boat. By that point, they can be extremely symptomatic, especially if they've got pancreatic cancer. They're on FOLFIRINOX, then they're going to get symptoms really, really quickly. So we need to make sure that we're looking at the cycles of treatment, we're minimising any symptoms, and we want to consider how are we going to pick up the raised glucose levels early, and we need to also have a look at what treatments that they're on for the diabetes as well. So are the appropriate treatments that they're on? And I'm going to cover that a little bit later. So if we're looking at HbA1c, we've already said it's a 3-month average. But what we do need is a baseline. HbA1c is always really useful at the beginning of treatment, and most cancer treatment facilities will be doing a an HbA1c and a random glucose, certainly when patients visit and start treatment. So if we're looking at glucose monitoring, we need to make sure that we're doing it at a specific time. So could we just go on with the slides? Thanks. So pre-evening meal, why would we pick before evening meal for patients to test? A lot of patients will test first thing in the morning and they'll say, oh, my blood sugars are great. So why are we testing before evening meal? Steroids, absolutely. So, and I mean, all steroids are slightly different, but to keep it simple, generally, most steroids are taken in the morning, some at lunchtime, which is fine, but the effect will be that the blood glucose rise through the day. So the highest readings generally are going to be around evening meal. So if we can pick things up really, really early, we don't want, if our patients are just on metformin and they've got no history of diabetes, we don't want them to be having to prick the finger every before every meal and before bed. It's not going to improve the quality of life, and it's not necessarily going to show us anything. So if we can ask them to test their glucose levels before their evening meal, then we're going to pick up where it's highest if they're on the steroids. So we also want to make sure that we're not testing on, between cycles. We want to make sure that we're testing treatment when they're on the steroids or when they're on the treatment, because that's the point where if everything's stable off cancer treatment, then we need to be checking things when they're on the cancer treatment, because quite often what happens is blood glucose levels rise during treatment and then fall in between cycles. Yvonne, I'm just actually going to come on to CGM on the next slide. So it is a really, really good tool that we need when we know that the control is suboptimal. So, but when we're just looking at identifying and picking things up early, we may not have an issue yet. We just want them to test before evening meal during the cycles. If we find that the glucose levels are starting to rise, I'm going to go through treatments a little bit later, but we need to consider adding in a bit of gliclazide. And I'll go into gliclazide in a little bit more detail. But what we want is if the glucose levels on sort of 2 or more occasions at pre-T are above 12, then we want to get things in early. So we start a bit of gliclazide at that time. We don't want to wait for the readings to be 15, 18s, 20s. We want to keep things as tight as we can. We're not looking, during cancer treatment, we're not looking for glucose levels between 4 and 7. Highly unlikely we're going to get them. But what we do want is to try and keep them below 13 for the majority of the treatment. And then what we want to do is get that gliclazide in and get them sent to referred in at that point to the diabetes specialist team. We can then assess what treatment they're on, the likelihood of how bad things are going to get, so the length of time they've still got to go through the full treatment, what treatment they're on, and potentially we can send them back to you with a titration plan for the gliclazide, but it's more likely that we're going to take those patients on so we can start insulin quickly if we need to. It's really important that we explain this to the patients, that the importance of monitoring the glucose levels. Quite often their head is full of cancer. A lot of them think they're not going to be here, so why do they need to check the glucose levels? Their first thought is, well, this is it. What's really, really important is stressing to them that if we can keep their blood glucose levels at target, then their cancer treatment is going to be more effective. Plus, if we keep them at target, they're going to tolerate the cancer treatment better, so they're going to have less symptoms, so the quality of life will be better. When I was working at Christie's, the patients just weren't interested in the diabetes at all, and what if you've got somebody coming into cancer treatment that has had type 2 diabetes for a while, they've been pecked at about getting good control and everything else. Now they've got cancer, and it's like, well, it doesn't matter, does it? Because I'm not going to be here in however many years' time. So what's really important is to get through to them that it's the quality of life and the effectiveness of the treatment. It is really, really important at a time when they really don't want to be interested in it. Sometimes that's really quite a challenge. Okay. Another quick and really easy thing to add on when you're getting somebody monitoring the glucose levels is urine keto sticks. Explain how to use them and when to seek advice. When we get referrals, quite often glucose levels are far too high. People haven't got keto sticks. We don't know if they're safe. What we don't want to do is get a referral for somebody who's on cancer treatment and end up having to admit them to hospital. We don't want them going into hospital. It isn't the place for them. They're in there enough when they're having the treatments. So what we want to do is make sure that we know whether they're safe or not. So if we can just check whether they've got ketones, then we know whether we can start insulin there and then, or whether we've got time, to wait and discuss it with the patient, or whether it's an acute thing and we need to get them admitted. So we'll get them blood ketone testing. But just urine sticks will give us an idea. So it's a good starting point. Because you're all from different areas, if you're used to prescribing blood keto sticks, then get them in. That's absolutely fine. But I know some areas urine ketones, we're lucky if the GPs will prescribe, well, even think about ketones. So urine keto sticks are about all we can get. But if you are used to doing blood ketones, then that's great. But obviously you'll need to explain to the patient how to interpret the results. Sometimes it's easier just to say we're on a stick, and if it turns purple, we've got a problem. So Yvonne's already mentioned about CGM. So for those of you that, I think everybody will know what CGM is. So it's continuous glucose monitoring. So things like the Freestyle Libre, we've got Dexcom 1 Plus, we're on Libre 2 Plus now. And these are available for the GPs to prescribe. Some of our district nurses, and certainly the practice nurses now, are starting to prescribe them. So when would we look at sort of CGM rather than just the finger prick testing? So we want to consider, so if we've got somebody that's got peripheral neuropathy and they've had elevated glucose at tea time, we're going to want them to start testing 4 times a day, because we want to know, is it only just getting up to 13 at that one point in the day, or are they up right across the day? We need to know that to decide what we're going to do from a treatment point of view going forward. So if people have got peripheral neuropathy, it's going to be really challenging for them to test 4 times a day. We need to keep in mind that quality of life, and we want them to sort of comply with testing, understand the importance, but if they're in pain and they've got pins and needles and they're struggling, then it's really not something they're going to want to do. So CGM is great in that situation. If they're only needing to monitor once a day, then what we find with the CGM, it's great, but it's giving them too much information, and they'll worry about what they're eating, because they'll see that the glucose levels are rising when they've had the breakfast, which it does in most of us, unless you live on eggs at breakfast. I don't. So they'll start to worry that they're getting it shows you too much information. So we tend to just do it when we need to know what's happening right across the day. It also allows us to see what's happening over the night, which is really, really important sometimes. We need to take into account, obviously, the patient's dexterity and cognition. However, we also need to take into account just simply their headspace. Have they got the dexterity, the understanding, the headspace when dealing with the cancer treatment to start glucose monitoring? So they need to change the needles, they need to be able to get the test strips into the meter, they need to be able to see the result, know what to do with the result. So sometimes it isn't appropriate for them to use a blood glucose meter. So again, that's when we'd potentially use the Libra or the Dexcom. A lot of patients have anxieties, obviously, certainly when they're going through cancer treatment. There's anxieties around actually doing the glucose results and the finger prick test, but then there's also the anxieties over the results that they're getting. And I've had patients who I've started on CGM because I've thought it's going to be the better option, and actually it's caused them huge anxiety and they've asked to stop it, which is absolutely fine. I've also had people that absolutely love it because they can share the data with the families and they know that things are staying on track. So I think what's really important, and it goes for anybody with diabetes, not just those with cancer and diabetes, that when we start any CGM, we explain the results straight away. What do they expect to see? And that actually the glucose levels will go up and down. We're not expecting 100% time in range. So that's okay. They need to try not to be anxious about it. If they're anxious, then we could go down the line of saying, if you think it's elevated, we're on a keto stick, and as long as that's okay, then don't worry about it. That's another reason why quite often I certainly give out urine sticks and blood ketone sticks, because when people are really, really anxious, they're going through the blood keto sticks and it's not clinically indicated, will bankrupt the NHS. However, they're doing it for their anxieties and to make them feel safer, which is absolutely understandable. So if we give them urine sticks, they're nice and cheap and cheerful. They're not clinically unwell with symptoms of diabetic ketoacidosis. It's just the bloods are high and they're worrying about it. Then they can wee on a urine stick and just give themselves that little bit of reassurance at home. And we want to make sure quality of life is the top of our list the whole time. So the benefits of CGM, it's pain-free and it's easy for the patients to use. It also means that we can remotely, if they're using the mobile phone, any healthcare professional, so you can get them in your practices. It's a free software. It's a cloud-based software that you can get accounts from the companies, so you can see exactly what's happening with your patients right across the day. I've recently had a gentleman, unfortunately he died a couple of days ago, but I wasn't aware of him, and I got an urgent call saying that he couldn't test his glucose levels, his phone wasn't working, he'd got confused and had changed some settings on his phone because he was desperately wanting to stay independent. So I went out, his wife wasn't coping, was exceptionally anxious. So I went out, fixed the phone, got it data sharing again with me, so that I'm not constantly having to ring his wife to say, what are the readings? What do we need to do? Do we need to change anything? We didn't know at that point. He went down exceptionally quickly. But just that reassurance from his wife that I said, I will check every morning, check the glucose levels, and if we need to change anything, I can do it with the district nurses, to see how things are going, was really, really sort of comforting for him and his wife. So the remote data facility is really, really good if we can get it. Okay. So the slide I wanted to put in about diagnosis of diabetes during cancer treatment. Generally, diagnosing diabetes is done off an HbA1c now. We're not going to have that information. We're going to be going off glucose levels, and if they haven't had diabetes before, then quite possibly they're going to end up with steroid-induced diabetes. What we need to keep in mind is that when people are on immunotherapy, they're at risk of developing immunotherapy-mediated type 1 diabetes. So we don't want to automatically presume that somebody has type 2 diabetes. When we go on to the treatments a little bit later, the type 2 treatments that we use as routine now certainly aren't appropriate in this group of patients. So sometimes you may not know, depending on where you're working, you may not know whether the patient's on immunotherapy chemotherapy, whatever. So just bear in mind that potentially it may not be type 2. So generally, type 1 diabetes following immunotherapy generally comes on within sort of three months, but it can be up to 12 months. It's a sudden deterioration in glucose levels, and there is the risk of diabetic ketoacidosis, which would mean our patients need to get into hospital. So it's another good reason for giving out those keto sticks, and also making sure that the first treatment that you start is gliclazide. So we stick the gliclazide in, get them keto monitoring, and then hopefully we can pick up the diabetic ketoacidosis before they end up being admitted to hospital, certainly not requiring ITU. And then that quick referral to the diabetes team. So it'd be the diabetes team that would do the bloods to confirm the immunotherapy. They would be treated, the type 1 diabetes, but they would be treated with insulin. If the gliclazide doesn't work, they'll need insulin. So clinically, all the patients will be treated the same, but it's really important for future care that we know whether it is immunotherapy mediated type 1 or not. Okay, we got a question on that. Yeah, no, any of the immunotherapy can cause. So, you're really testing me now, trying to remember the names. You lot will know the names better than me. So when I was at Christie's, it was they all said to me, just remember your MIBs and your MABs. But I would just make sure that we don't start any of the traditional, the more recent type 2 treatments on these patients. We go down the GLIC route, we get them testing for ketones, and we get them referred on, and then we can do antibody tests and things to confirm. So this is our first little break for any questions that you've got so far.
I think there was a couple in the chat, maybe, from earlier about steroids. Is the steroids taken in the morning?
Can I ask a question as well?
Lunchtime? Yeah, 1 second. Let's let Irene answer that, and then you can come in.
Sorry, what was that one?
It was whether steroids, if steroids taken in the morning, is the peak at tea time rather than lunchtime?
Yeah, so prednisolone will sometimes cause a rise at lunchtime, but if there's a rise at lunchtime, the rise at tea time is higher. So some patients, generally, your breakfast readings are great, and your lunchtime tend to rise slightly, tea time more. Bedtime, sometimes they're slightly higher, and sometimes they're on the way back down again, and then they drop again by morning. So that's why we tend to say tea time, but it may well be affecting lunchtime as well.
Thanks. Jenny, does that answer your question?
Yes, thank you very much.
Okay, Julie.
Before I was told to start a patient who was on treatment for, if they were a cancer patient and then they was on steroids, I was told to start them on insulin. Are you not advising that, or just go down the GLIC route?
Yeah, no, certainly. So a lot of primary care in our area don't start insulin. So if you're used to starting insulin, you're able to do that, then yes, absolutely. It means you don't need to take into account, the half-life of gliclazide and things like that, and whether the renal function's okay. So yeah, absolutely. We don't have that luxury. So all the patients that need insulin in our area come through to us. Some of the GPs will start Lantus, but that's a very, very flat profile. Levemir is obviously going out. So from my point of view, I tend to use Humulin I. Insulatard's also going out. So I tend to look at Humulin I for steroids. I know when we were at Christie's, we used Levemir quite often because of the cumulative effect of the steroids. The Lantus is too flat a profile. Okay. So we just need to hope that Lily don't withdraw Humulin I.
Okay, all right. Thank you so much. That's helpful.
Okay, no worries.
Thanks. And next we've got Rahana.
Hi, I was just going to ask, I've had patients on multiple steroids at multiple times of the day, so
Yeah.
twice daily dexamethasone. Does that mean we would need to give the gliclazide or Humulin twice a day for multiple peaks?
Yeah, not necessarily. So again, it depends. Prednisolone obviously is generally once a day. Dexamethasone generally twice a day, but it tends to be breakfast and lunch time. So you can tend to get away with the gliclazide just in the morning, or the insulin just in the morning. What we want to try and do is keep it as simple as possible for the patients. So if we can keep a really simple regime and keep it to once a day, then that's going to be the most easy for them if we can do it. But if the glucose levels are showing that there is a rise at breakfast, we're going to have to put something in the evening.
Great, thank you.
Okay.
Thanks. And then we've got Kasia Harford.
Hello there. My question is about immunotherapy. Can you hear me?
Just, yeah.
Oh, sorry. Okay. So, immunotherapy. So I think you said to send bloods for antibodies for type 1 diabetes. Is that right?
Yes. Yeah.
Yeah. So I have a very interesting patient who we were advised by our consultant to treat him as type 1, even though his sort of clinical picture was type 2. He's on immunotherapy and the diabetes was induced by that. His antibodies and his C-peptide studies came back negative.
Yeah.
He is very prone to ketosis, and he actually had to be admitted due to DKA when he became unwell.
Yeah.
So that the markers didn't sort of seem to be, the antibody testing didn't seem to be a reliable thing. It came back negative, but they behaved like a type 1 patient.
So antibodies, I think it's 10% of people with type 1 diabetes don't have antibodies. So the antibody test isn't,
reliable.
Yeah, exactly. So we would go off clinical presentation. And I think from primary care sort of point of view, we'd be looking at getting some gliclazide, because it's if you don't start insulin, and get refer on to specialist services, because these patients are going to need a lot of intensive input. And I don't know where all of you are from, or whether some of you are from specialist diabetes services or not, but the presentation is very much not for specialist nurses, only because we would have, there's no way we can cover it in an hour to go through everything. So it's very much for people to be aware that there is that immunotherapy mediated type 1, and either start insulin or gliclazide, whichever you feel most comfortable with, get testing for ketones and refer them on quickly.
Yeah. And do you agree that the blood sugars start rising well before the actual clinical picture shows that they are having an infection brewing? Because this is my impression, that the blood sugars rise, but the patient still feels clinically well, and it's only sort of after 3 days that they start feeling unwell, but the diabetes is already becoming very difficult to manage.
Yeah, which is why we want them testing right from the beginning, ideally, and then we can pick things up really, really early.
Yeah, brilliant. So, thank you so much.
Okay, just one more thing, Kasia. Some of our patients that have type 2 diabetes can also develop autoimmune type of diabetes, so become insulin requiring. I think that's really, really important to remember as well. If there's a sudden deterioration, you obviously treat it clinically, which will be insulin, but get them referred on really quick.
Yeah, I'm a DSN myself. And,
well, there we go then.
What I actually find is that a lot of patients with cancer are started on steroids, but diabetes is not given any thought, and they develop extremely high blood sugars, which are then they get referred. We manage the diabetes. The blood sugars drop suddenly, and they lose their eyesight, or their eyesight becomes very impaired, and it's very distressing for them.
Yeah.
So it is my main bugbear.
Yeah. So that's why we want primary care to pick it up really, really early, get them monitoring if they're on steroids. It isn't going to cost the earth, because it's once a day if they don't have diabetes or the bloods are well controlled, and then they can pick it up early, start testing 4 times a day and get them referred in straight away.
Yeah, I think it's that awareness about sort of thinking about diabetes early on.
Yeah, absolutely.
Just going to interject. Thanks, Kasia. I'm just going to interject in relation to the time, Irene. There's still a few more questions in the chat, but I'm just mindful that you've still got some more stuff that you'd like to present. So should we move on? And then if there's questions that haven't been answered at the end this time, we can go back and answer them. If not, perhaps you'd be able to kind of answer some of them in the chat afterwards, because I think the chat will stay accessible to you after the meeting.
Yeah, absolutely.
Yeah, lovely. Thanks.
Thank you. So when we're looking at routine type 2 diabetes treatments now, gliclazide isn't one of them. Obviously, insulin isn't one. So we've got our SGLT2 inhibitors and our GLP-1s. So if you can think back to the beginning of the session and what our priorities were for diabetes treatment in cancer patients, can just jot some in the chat while you we had nutrition, quality of life, symptom control, nutrition, weight gain, weight maintenance, so if we look at the SGLT2 inhibitors, I don't know if you're all completely aware of how they work, but they work on the kidneys, and a good side effect of them is weight loss, because you wee out glucose in your urine, so you're weeing out calories. However, if you've got a lot of glucose, potentially you're going to lose a lot of urine, so you're going to be going to the toilet a lot, and you've also got risk of thrush or UTIs. There's also the risk when people are getting dehydrated if they haven't got enough insulin on board for diabetic ketoacidosis. So these aren't really medications that we want to keep in during cancer treatment. However, if we've got a patient on these treatments for heart failure, then the specialist team are going to have to make that judgment as to whether it's important to keep that in for the heart failure because they're symptomatic and we haven't got any other treatment options, or whether it's going to be more beneficial to stop it to get on top of side effects and symptoms. Once glucose levels are under control, then the SGLT2s, you're not going to get many side effects from them, but we need to have that glucose under control. So if somebody's come to you with elevated glucose levels, then we're certainly not going to start those treatments in that group, this group of patients. And then our GLP-1s are obviously there to reduce appetite. Well, we want these patients to eat what they can. They're probably going to be sickly and only want to eat certain things anyway, so we don't want to reduce that any more than it's reduced already. And weight loss, and we've already said we want that weight gain. So I have had patients who've been started on GLP-1s, they've lost loads of weight, didn't know that they had cancer. We've thought that the GLP-1 has been exceptionally effective, but actually they've had cancer, and the patient then blames the GLP-1. So I'm not saying we don't start people on a GLP-1 because they may have cancer ongoing, but if we've got patients that have come to us and potentially the picture doesn't look right, we rule everything else out first and make sure that there isn't any cancer before we sort of go down a GLP-1 route. Okay. So gliclazide, why are we going to use gliclazide? I think what we, when I sort of do sessions, certainly around the Northwest, you'd think gliclazide was the devil. So it's spank the pank, and you're going to, they'll put on loads and loads of weight, and you'll kill off the pancreas. Actually, NICE guidance still has gliclazide in it, but it isn't there as routine treatment anymore, which is obviously understandable. But NICE guidance does say to consider gliclazide as rescue therapy in the presence of symptomatic hyperglycemia. It also says insulin. So glycoside or insulin, it says. So if you are used to starting insulin, then obviously you can go down the insulin route. We have some patients that are very, very anxious around insulin. So if we get some glycoside in, we're sort of paving the way. But glycoside is very, very quick and effective, and it gives us an idea of whether we have got pancreatic function or not. It's a safety net until they can be reviewed by the specialist team. Obviously, the side effects are reducing glucose, which is what we want, and weight gain, which is what we want. Generally, it's really well tolerated. And it gives the patient sometimes time to process the potential need for insulin if they're really, really anxious about it. Obviously, if we have to go straight to insulin, then we have to. We don't have a choice. But certainly in primary care where I am, if glycoside can be started, then it gives the patients time and it buys us time. So it's really useful. Okay, so glycoside generally, we've got the standard release tablets, so 40 milligrams BD up to 160 milligrams BD. But if we've got somebody that's on steroids and the glucose levels are only rising in the evening, we're only going to give it in the morning. So we generally want it 30 minutes before food, so breakfast and evening meal as routine. When people are on steroids, we can give up to 3 80 milligram tablets at breakfast. So generally it's 2 tablets at breakfast, 2 tablets at evening meal, which is the standard sort of routine dosing. But when they're on steroids, we can do 3 tablets at breakfast, and we can also put in a lunchtime dose rather than an evening meal dose if the bedtime readings are staying high, but the breakfast readings are dropping low. So if we put a tea time dose in, that'll affect breakfast and breakfast readings, supper, and breakfast readings. Whereas if we put it in at lunchtime, it's going to affect tea time and supper readings. The slow release version we tend not to use, so it's not specific enough. So we have got the slow release, but it's not advisable for use with steroids. Okay. So I think you've all sort of gone through about the effect of steroids. We've also got the glucose transporters as well. So folfirinox is a major one. It's given in glucose. So if you're giving somebody folfirinox with IV glucose, the likelihood is that their glucose levels are going to rise. And you're giving them steroids as well. So what we want to make sure is that we're on top of things. So if you're aware of the different types of treatment and how they're administered, then obviously you can deal with them. But as far as I'm aware, we've got quite a few people from primary care, and our practice nurses, GPs, they're excellent, but they can't specialise in everything. So knowing whether a treatment is given in glucose or saline is not going to be top of their agenda. So just being aware that the fact that some are given in glucose transporters. So if you say the name of the treatment to a diabetes specialist nurse, I won't pick on you, Kasia, but then they'll probably be able to say, oh my goodness, yeah, we need to get insulin in straight away. Or well, no, actually, it probably won't affect things too much. We can probably get away with it. So like I've said before, the steroid profile tends to be morning glucose is good, they rise through the day, and then we get the sudden drop overnight, and it's cumulative. So as the cancer treatment goes on and they go through the cycles, their glucose levels are going to get worse. So what works cycle 1 is unlikely to work cycle 8. We're going to have to keep increasing treatment. So get them to the specialist nurses so we can get the insulin in. Quite often what they're going to need is 2 weekly reviews. So not everybody in primary care is going to have capacity to do 2 weekly reviews. So it's another reason why we get them through to the specialist team so we can keep on top of things. So I'll answer this question because looking at time. If we think back, obviously we've said glycoside and ketone monitoring, insulin if you can do it. Those of you that start insulin, I'd really like to know where you are in primary care because I might move areas. So we've got glycoside and ketone monitoring. refer early to the diabetes specialist team, get them on CGM if you're happy to start it. And then we just need to set up the data sharing. That's always really, really useful if they come to us already on a Libra or Dexcom. They'll need the individual steroid and chemo plan, and generally a reviewing every 2 weeks to adjust that plan. So they'll end up with food insulin, steroid insulin, and then correction doses as well, certainly if they're on Folfirinox. So they end up giving quite a lot of insulin during cycles, and then obviously that suddenly drops in between cycles generally. Okay, so things to remember. So we want to, the efficacy and tolerability of cancer treatment is linked to good glycemic control. So explaining this to any of your GP colleagues, to the patients, is really, really important, because obviously we need them on board. We want to anticipate any potential problems and pick things up really, really quickly, sorry. And we want to assess the current treatment. So are they on GLP-1s or SGLT2s? Do we need to stop them? Metformin, we keep going, because there's evidence to say that metformin is actually beneficial in cancer treatments. So as long as it isn't making them sickly, then we continue it. So at one point I used to stop it because thinking it's going to put them off the food and make them feel sickly. But actually, when I did my dissertation, it's really, really important to keep in if they can tolerate it. Okay. Monitoring is essential, and we want that finger prick testing or CGM rather than HbA1c, so we can catch things really, really early and refer them early. So adding GLIC or insulin and get them testing for ketones, refer them early to the diabetes specialist team. Okay, so those are just the links to the sort of general guidance that's out there that's really quite useful. I feel that last bit was really rushed, but let's get to questions.
So we've probably got about three or 4 minutes maximum for questions.
Yeah.
There's a few in the chat which I can have a look back at. There's one about the glucose care treatment plan. Who produces it?
That'd be a specialist team. Yeah. So I think from a primary care point of view, identify it, start a bit of GLIC, get them monitoring and referring quickly, and we look at the intensive plans.
Okay, and Rahana, you've got your hand up.
Just another question about, so sometimes patients are on steroids for like 3 weeks and then they have a couple weeks break.
Yeah.
Are you stopping, like using Diclazide only when they're on the steroids and then stopping it when they're on their break, or the same with insulin?
Yeah. So it's a really good question. It depends. So it depends on the monitoring. So quite often patients will need extra insulin on steroid days and through the cycles, and then that'll reduce or stop in between as they go through the cycles. So if we get to 8 cycles, then generally they'll still need some in between, but they'll need more during. So initially we just start it on the steroid days until we've got that full profile, and then we can make that decision whether it needs to carry on or not.
I'm not sure if this was answered. A patient that's not known to have diabetes, how often and when would you advise testing and those taking high dose steroids?
Yeah, so I would sort of get, I mean, there's guidance in the oncology guidelines, but on the steroid ones, but I would say to get them testing on the treatment days at tea time. And if we're getting readings above 12, then we need to start on treatment. If they're consistently below 10, then obviously they can have a bit of time off treating. But if they're going to be on steroids a long time, then maybe twice a week at evening meal ongoing, rather than every day.
Okay, running very short of time, but maybe the last question is someone's asking about glycosides and giving them morning and lunchtime doses. How do you dose it, as it's usually given BD?
Yeah, so you initially start at breakfast and monitor the tea time glucose levels. Once you get up to 3 tablets at breakfast, if the evening meal levels are still elevated, then you can add in a tablet at lunchtime.
Well, and then last question is, could you do further training for nurses that do start insulin? So would you be willing to do another session? People are asking. So
Yeah,
that's
absolutely.
yeah,
Yeah.
brilliant. Okay, I'm sure we can have a chat and organise something.
Yeah,
Thanks,
I'm
Irene.
quite happy, Sandra, if you want to give out my email, and then I can always, give links or advice if there's any that's needed. That's not a problem.
Excellent. Okay, I'm probably gonna end the questions there. A couple more slides I want to show some of the QR codes that people are asking for other events that we're running. So thank you, Irene, for your presentation. I think it was really, really comprehensive. And you did a brilliant job of getting through so much information in such a short period of time. I appreciate that overall challenge, as you said at the beginning.
Big
But thank you so
challenge.
much. Right, so just a few last things from us. I've just gone past. Call to action. We're always wanting to increase the size of our community of practice and opportunity really for you to help us. So if you know other colleagues who'd be interested in some of our content, please pass the information on, and people can sign up to our mailing list. My contact details are here, and I'm going to show a QR code on the next slide that takes you through to our mailing list as well. So that's that, and we'll be sharing the slides afterwards. So if you haven't got time to scan it now, that's not a problem. Someone saying they can't use the QR code, that's fine. You can use the email address. This is our next webinar that we've got planned. It was on the 23rd of January. You can book through a link on the slide, which we'll be sharing with you afterwards. And it's looking at late effects for cancer treatment. So it'll be a very interactive session with a couple of our community of practice steering group members running it. And lastly, feedback. So your feedback's really important to us. It really helps us shape our webinars and our events. So if you can use the QR code, you can scan it now. If not, when we send the slides through later on, you'll be able to just click on a link and go through to the form. It literally will take you 2 or 3 minutes to complete it. But the feedback for us is really useful in terms of improvements, but also in terms of evaluation of our community practice and our sort of fundraising for for forthcoming years and events that we want to run. So please do complete it. It's really very valuable to us. And then lastly, thank you all for attending today. And for Irene for her time in presenting. It's the first time we've run anything on diabetes and cancer, and a few people had asked for it. So I'm really grateful, Irene, for your time today, that you were able to come along and deliver the session. So thanks
No
very
problem
much.
at all.